Thursday again, HPL seminar. So today, it's my pleasure to welcome Ricky Watari. So Ricky Watari received his master's degree from the University of Sao Paulo in Brazil in 2011 for his study in the effect of diabetic neuropathy severity classified by a fuzzy model in muscle dynamics during gait. Before coming to Canada, Ricky's working history was impressive. He worked as a physiotherapist, an acupuncturist, a Pilates instructor. I believe students in kinesiology graduate studies are well aware of this, and a teacher in the massage therapy program. In 2014, Ricky started his PhD degree with Dr. Rick Ferber. He's interested in the applications of machine learning techniques in running gait kinematic data for the development of technology to improve clinical practice, specifically in the treatment of patellofemoral pain. Ricky has 3 first-author and 7 co-authored publications so far. In his leisure time, Ricky enjoys cooking and appreciating food from all parts of the world. He is also an astrology enthusiast and loves doing star charts reading for his friends. Ricky also loves dancing, especially Brazilian dance styles such as forró and samba. For those of you who have attended the International Society of Biomechanics Conference in Brazil in 2013, you may have witnessed Ricky's dancing performance. However, we may have to wait for the next occasions to see Ricky dancing. Today, he will instead tell us more about his research in evidence-informed methods for predicting rehabilitation outcomes in patellofemoral pain. Please, Ricky.
Thank you very much for that very kind and different introduction. So I'm going to start this off by talking about how the world is a bit worried. So we're living in an age in which the rates of obesity, cardiovascular, and metabolic diseases are increasing. And people are getting worried about this. And one of the measures to try to confront this is through regular physical activity. And people are starting to do that. People are actually running for their lives. So running has become a very, very popular modality of physical activity in the past 20, 30 years. And people have been participating more and more into running events and running in their daily activities. So just as an example, in the US alone, there was a 300% increase between 1990 and 2013 in participants in running events. As another example, we can see a growth in the popularity of marathon events, how people participate in marathon events. So worldwide, there's been a 13% increase between 2009 and 2014 in participants of marathon events. If we take Canada's statistics, for example, I'm just zooming in here from this number, Canada had an increase of almost 11% of participation. So apparently there's good news here. People are getting more active, people are trying to prevent diseases, trying to stay fit, stay in shape, but we might be paying a price for this. So we might be running towards an injury, because running is related to the incidence of musculoskeletal injuries. So in the literature, there is talk about 20 to 80% of incidence of lower extremity injuries. And a lot of people that start running, they actually stop after a while. And 30% of those who stop running are actually due to running injuries. And a portion of these people who stop running, they not only stop running, but they stop also all types of physical activity because they start to get discouraged. So there's a problem that we have to deal with here. Now, the knee is one of the most affected sites when we talk about running-related injuries. And among the injuries in the knee, patellofemoral pain is the most common one, encompassing around 20% of all of the running-related injuries. Now, what is patellofemoral pain? This is a disease that is defined by pain around or behind the patella, so specifically in the patellofemoral joint. And this pain is aggravated by at least one weight-bearing activity, such as squatting, stair ambulation, running, walking, jumping. So running is among those activities that aggravate this symptom. Now there's good news here. Usually the treatment of choice for patellofemoral pain is a conservative treatment that usually involves exercise, insoles, and other types of therapies. And most people do well with this type of conservative treatments. However, there's still 15 to 40% of people that are not successful with these types of treatments. So the first choice that a clinician would usually have, and this is recommended in the literature, is to prescribe exercise therapy that usually involves quadriceps and hip strengthening programs for these patients. Now, these exercises have been shown to be effective in the reduction of pain and improvement of function in these people. However, the ones that don't really do well in these conservative types of treatment, they go through the program and they end up getting frustrated because they don't get better. And they end up going in and out of treatment through a long period of time. And sometimes they even have to change their activity, change their style of life because of this pain. And this is not a self-resolving type of pain. There are evidence out there that there are persisting symptoms in these patients even 10 years after the diagnosis. So this is something that most people that start with this type of pain will carry it through a long period of their life. So looking at these treatment subgroups between who responds and who doesn't respond, I'm just going to analyze a little bit this data from this randomized control trial in which our research group participated. This was a multi-center randomized control trial in the treatment of patellofemoral pain. 199 patients were treated with exercise therapy. And what happened in the end was that 80% of these patients were responders. They got well with the treatment. But 20% either didn't respond or got a little bit worse after the treatment. So if we look at the general picture, it's a good number, 80% of success rate. Wow, it's really good. But let's break this down in another way. So 199 patients, they went through 6 weeks of treatment, 3 hours per week. This sums up to over 3,500 hours of treatment. Now, from the study, 42 of those 199 were considered non-responders to the treatment. So in the end, we have 756 hours of ineffective treatment that occurred in this process. So if we were able to identify these subgroups, identify the people who would most likely respond to this type of treatment, it would be a good start for developing treatment optimization strategies, developing better tailored therapeutic strategies, and this would improve clinical practice. Now, there are some prediction models out there that try to look into who's going to do well in these types of treatments. And what they found in general was that patients with longer symptom duration and patients with lower anterior knee pain scores, anterior knee pain scale scores, this is a questionnaire that is specific to measure the function in patellofemoral pain patients. So these types of patients tend to have a poor prognosis in treatment. However, these models only predict 19 to 33% of the variance of the results of the treatment. And they aren't really effective in identifying who is going to do well or not in this type of setting. Now, one option that hasn't been very much explored in patellofemoral pain is the use of gait analysis as an objective measure to try to improve these prediction methods. As an example here, Dylan Kopsar from our group, he developed a classification model using patient-reported outcomes and gait kinematic variables of knee osteoarthritis patients. And he classified these patients into high, low, or non-responders to exercise treatment. And he had an 85% classification accuracy, which is pretty good. It gives us the hope that we can actually use this type of model in other types of diseases as well, such as in patellofemoral pain. So the purpose of this presentation today is to propose treatment outcome prediction models for patellofemoral pain using a combination of clinical and demographic variables, which have been used formerly, and 3D gait analysis variables. Now, this will be divided into two studies. The first study, for the 3D gait analysis, we use the lower limb joint angles from the kinematics. And for the second study, we use pelvic accelerations as data from gait variables. Now, the first study has been published in Clinical Biomechanics, and the objective was to determine whether a combination of 3D lower limb kinematics and clinical variables would be able to classify patellofemoral pain patients according to treatment response following a 6-week exercise-based rehabilitation protocol.
Ricky, can I just ask a quick clarification of
Yes.
non-responder? So is this people who are still running or they're not running anymore?
For the patients from the randomized control trial?
Well, in general, when you say non-responder, are these people running or not running?
I don't know if there's a clear separation of that in the literature. So it's kind of mixed. Some people stop running, some people don't stop running. And
well, the reason I ask is that usually if you just stop running, the pain will eventually go away. And then I'm wondering, is that called, that's my therapy, is don't run. Is that considered responding or not responding? Because when they run again, maybe they will develop pain again, but at least when they were not running, the pain went away.
Well, the people who do stop running and go back, and if they have a mechanical problem that is leading to patellofemoral pain, they'll have a reincidence. So I wouldn't say that's a good response.
Okay, thanks.
Ricky, just directly answer the question. What is the exact criteria and who is it based on to define a responder and a non-responder, please?
Yeah, so I was gonna get into that here.
Thank you.
But, well, let's just go through this. So for this study, we use the same patients from that randomized control trial that I mentioned earlier. We took 41 patients out of those 199 because these were the ones that had useful data for this type of analysis. So all of them had at least 4 weeks of patellofemoral pain and at least 3 centimeters of pain measured in a visual analog scale. And they all went through either a hip and core focus or a knee focused exercise program. Now, these 41, after the intervention, were classified as responders or non-responders to the treatment. So we had 28 responders and 13 non-responders. And the success criteria, which is what we just asked now, was a minimum decrease of 2 centimeters in the visual analog scale and a minimum increase of 8 points in the anterior knee pain scale. Now, this was defined as the minimum detectable difference in these scales that was published by Crossley in 2014 and 2004.
So, we didn't tell them to stop running or not. We treated them as patients as you would in a clinic. So some of the responders stopped running, some kept running. Same with the non-responders. Just told them the specific instructions were do not run to the threshold of pain, to the point of pain. If they wanted to keep running on a weekly basis, fly at it.
Okay, and then the visual analog scale, that's asking them, are you experiencing pain right here as you sit down filling out this form?
Yeah,
or is it when you run?
Average weekly pain during activities?
During...
I think there's lots of different VAS scales. This one specifically was average pain during the week while performing activities.
Which could include running or not running.
Correct.
Yes. So from the pre-treatment, so before the treatment, they had their, all the patients, these 41 patients went through a gait analysis. So we collected their gait kinematics and their clinical variables from before the treatment. For the 3D joint angles, they ran on a treadmill at a speed of 2.7 meters per second, and we calculated their hip, knee, and ankle joint angles. And the clinical variables were the pain visual analog scale and the AKPS. So, and these variables were not different between responders and non-responders at baseline. So these variables were combined as possible inputs into a classification model, in this case a linear discriminant analysis, and we use a forward feature selection and a tenfold cross-validation algorithm for this classification model. So the classifier, again, took these data to try to separate these patients into responders or non-responders. Then we compared the results from the model with the results from the RCT to see how the model performed. Now, the 3D joint angles went through a data reduction process with a principal component analysis. So in the end, we had 68 possible input features that could have gone into the linear discriminant analysis. So the performance of the classifier, in the end, we had a cross-validated accuracy of 78.1%. Now, this is the confusion matrix where we're crossing the data from the RCT, who's responder, who's a non-responder, and the positives and negatives from the classification model, being positive being a responder for the classifier and negative a non-responder for the classifier. And looking at this table, we can draw some other performance measures, such as the recall rates. So the recall rate is, out of these 29 people that were classified as responders by the model, how many of them were actual responders? So the recall rate for this classifier was 89.3%. And we can also look at the precision. How many of those 28 responders were actually detected by that model? And the precision rate was 86.2%. We can also calculate a harmonic mean between these two values, which is this F1 score, which goes from a scale in a scale from 0 to 1, and the model scored a 0.88. So all of this is indicating that it has a good classification accuracy between 80 and 90%, especially when we're talking about detection of responders. However, when we look at a bit of a bigger picture, we can calculate this Matthews correlation coefficient, which is also a scale that goes from 0 to 1. And the scale goes up when we have a good rate of correct classification, so true positives and true negatives, and a low rate of false positives and false negatives. So it has to get things right, and it can't get things wrong. That's how we get this coefficient up. And this one had a low 0.36. And it's probably because of this false detection rates in the non-responders and the negative ones in the model. So it doesn't do quite as good a job when we're talking about the detection of non-responders in this model. Now, these were the features that were selected by that classification model. So none of the clinical variables were actually selected by this model, so they were just not deemed as considered important in the to distinguish these two subgroups. And these are the components from the gait kinematics, PC17 and PC35, that were selected by the algorithm. Now, this pie chart is a little confusing here, but what it's representing here is the representation of each component in each joint. So in red, we have the ankle joint. In green, we have the knee. And in blue, we have the hip. And the darker shade is for sagittal plane. The intermediate is frontal plane. And the lighter shade is for transverse plane. So for example, PC17 had a great representation in the ankle joint, especially in the sagittal plane. Now I'm going to go into further details in the following slides for these pie charts. So to look into the differences between responders and non-responders, these graphs are the joint angles, in this case the ankle joint angles. that are normalized by stride. So we have in the gray area here the stance phase, and the white area the swing phase. And we have a rough representation of the regions where the PCs had a good high loading in this data set. So here for the ankle sagittal plane, the responders here in the dashed line, they had a very subtle lower dorsiflexion in the beginning of stance at the end of swing phase. And in the frontal plane, which had a big representation here for PC17 as well, the responders had a slightly higher eversion during the stance phase. Now for the knee joint, there was only a big chunk of representation in the frontal plane, and the responders had mostly differences in the swing phase of gait, of the running gait, and they had lower abductions of the knee during that swing phase. And for the hip, only the sagittal plane had a big representation here with PC35, and the responders had lower hip flexion and during the beginning and of stance phase and end of swing phase. There were some other differences in kinematics between these two subgroups, but they were just not chosen by the algorithm, so they weren't deemed important to distinguish these two subgroups. Now, this classifier chose only gait components, and it was able to achieve almost 80% of classification accuracy. So that's promising to tell us that this could be a possibility to be used as a prediction model in the clinical setting. However, gait analysis is still not yet widely accessible for clinicians to use. So they would either have to send people to gait research labs to get these types of results, and that's just not feasible. So how to make this more accessible? And to try to tackle that question, we tried to use data that could be acquired by wearable technology, such as these types of accelerometers. Now, we chose accelerometers because wearable technology because it's a very growing, fast-growing market in both industry and research, and it's very portable, it's accessible, and people can just put them on and go for a run, and we could have these types of measures for them. So the second study is currently in review in clinical biomechanics as well. And it was the same objective, but we used the pelvic acceleration, clinical variables, and we added a few demographic variables as well as possible input features in this model. Now, these are the same 41 subjects from study number 1. 28 responders, 13 non-responders went through the same exercise intervention. But instead of the joint angles, we use the pelvic accelerations. Now, full disclosure here, this is not collected by wearable technology. We just wanted to see if this type of data was useful in this type of model first. So we just took the technical markers that represented the pelvic segment, we calculated the center of those markers, and we used the double derivation of the position of that centroid using a Savitsky-Golay method, which is basically a moving average filter. And that's how we got these pelvic accelerations. So for the clinical variables, again, pain visual analog scale, AKPS, and we also added symptom duration, whether if it was a uni or bilateral involvement, or if they participated in the hip or the knee protocol as possible variables. And we also added age, sex, height, mass, and BMI for the demographics. So all of these went into the classifier again, but this time we used a support vector machine just to try to deal for a better dealing with the clinical variables that were binary, because the linear discriminant analysis couldn't do that as well. And again, the pelvic accelerations went through principal component analysis, so we had 86 possible input features for this model. So again, the cross-validated accuracy for the second model, it went up to 85.4%. When we look at the recall rates, it went up to 96% and precision to 90%. So the F1 score went up again, 0.93. So in the detection of responders, apparently it's doing a better job than the joint kinematics itself. And when we look at the Matthews correlation coefficient, it also went up to 0.69. So even for the non-responders, it's doing a better job. Not as good as for the responders, but still much better than the first one. And these are the features that were selected by the second model. Again, none of the demographics or clinical variables were selected by the model. And these are the 4 components that were selected from the pelvic accelerations. These pie charts are just representing, again, where are the representations of these components, but this time in which direction of those pelvic accelerations. If it's in vertical, in medial lateral, or anteroposterior direction of that acceleration. So again, comparing responders and non-responders, but this time this is pelvic acceleration. We have vertical, anteroposterior, and medial lateral. And I normalize this by step just because we're talking about an axial segment. So the white area here is stance phase, the gray area is flight phase of the step. Now, what we can see for these 2 components, PC2 and PC16, is that the responders had overall a lower variation of the magnitude of those accelerations. And the other 2 PC, they're higher order PC, so they only explain very small amounts of variation in the data. And what we could see is that responders had less of those small variations in the signal than the non-responders. So there are a few advantages by using the pelvic acceleration. First of all, there's a better performance. Now, the joint angles had almost 79% accuracy, and pelvic acceleration had 85%. When we look at the numbers, it doesn't seem like much of a difference, but if we take into account a critical binomial test, so this is testing whether this classifier would be better than a random classifier, random poll of classification of these patients, considering a distribution of 70% of responders and 30% of non-responders, which was close to the rate of our sample size, our analyzed sample here. There was a minimum accuracy that the classifier had to reach. And only the pelvic acceleration model actually surpassed that minimum accuracy to be considered statistically better than a random classifier. Also, pelvic acceleration can be acquired by wearable devices, as I mentioned before, and it makes things much more accessible in the clinical setting. Now, going back to that first example from the randomized control trial, we can try to tease out a few of the benefits that this type of model could bring. So we had around 750 hours of ineffective treatment. If we were to use the pelvic acceleration model, out of the 199, only 146 would be allocated into an exercise treatment protocol. So that would have around 2,600 hours of treatment. And if we consider the accuracy of the model, we would have around 15 non-responders among these 146, which would add up to 270 hours of this ineffective treatment. So we're cutting down on hours of treatment, cutting down on costs. So this could be very promising for the health system and for the individuals, the patients themselves. However, we're still talking about the best case scenario here, if this model were to really work this way in the real world. And we're still not sure what to do with the non-responders to the exercise treatment. There are other options, but we don't know to which one they would respond well. So this is just looking at this cost effectiveness, but we're not solving the world's problem yet. But it's a good start. So some limitations to these classification models. First, they were what we call optimistic models. So they're good at detecting the responders, but they don't do as well when we're talking about the non-responders, as I mentioned before. Also, we still have to test the generalizability of these models in the real world. So we have to get test sets of subjects that weren't involved in the training of that algorithm to actually understand if this model works in the real world. And we still have to actually test if data from actual wearable devices could be used in the same manner, because we use just data from motion analysis systems, and there might be some differences from all the calculations that we have from the motion capture data and the ones that come straight from a wearable device, an accelerometer, for example. And when we look at the selected features from these models, it's kind of hard to tease out what are the exact mechanical differences between responders and non-responders. So we still keep that question open because it's kind of hard to interpret those features, especially the pelvic accelerations and what do they mean mechanically. So the take-home message from this presentation would be that the use of gait analysis variables is useful and effective in distinguishing between responders and non-responders, specifically to exercise treatment. Now, especially considering the pelvic acceleration model, we have up to 85% of accuracy in the classification of these subjects. Now, this shows the potential for this type of method to be used to improve clinical practice using a clinically accessible and evidence-informed method. Thank you very much, and I'm open for questions.
Thank you, Ricky. Questions? Venus.
Nice presentation.
Thank you.
So I'm wondering, so do you have a kind of database for normal gait for people without any pain, and so you compare initially to show that people with pain, they have different gaits from no pain?
Yes, very good question. Thank you very much for that question, Venus. So I have to repeat the question, right? Yeah. So the question was if we have a comparison of control subjects that have no pain to try to compare them with the patellofemoral pain subject to see where the differences lie. Am I correct? Is that the question? So first of all, the literature already brings a lot of data on these differences between controls and patellofemoral pain subjects. So here are a few of the differences that have been found in a prospective study here. Oops, yeah. So they have especially differences in hip abduction, hip internal rotation, and rear foot inversion when compared to controls. And also, for the first model, the linear discriminant analysis one using the joint kinematics, what we have here is kind of the discriminant function score. So that model gives us a final function that gives a score to each patient. And these are kind of the distribution of those scores based out of those two principal components that were selected. And when I ran the stats using a set of controls that were matched for speed, age, and sex, the non-responders were similar to the controls, whereas the responders were a little bit different from the controls mechanically, considering those two PCs. So it kind of makes sense that the responders would do well, because if we consider this as like a normal, then the responders would have somewhere to go to using some sort of treatment. And the non-responders would have to do something else because they are already more similar to the controls.
So in your model, you put in the two different treatments. Did you look at what the results would be if you just analyzed one of the treatments? Because you're kind of putting in the confounding factor there, is not everyone's getting the same treatment. You have two different modalities, and either they're a responder or non-responder.
Very good question too. The reviewers always ask that question. So the question was if I did the analysis separately using only the ones that went through the hip protocol or the knee protocol, because that could be a confounding factor for the response to treatment. Now, I'm going to tease out this in a few answers. So first of all, for the classification model, especially for the second one, we included the protocol as a possible input feature, and it wasn't chosen as one of the features. So that leads me to believe that it's not really important in this case to separate between responders and non-responders because the model didn't think it was. Second, in the randomized control trial, there was an analysis, the distribution between responders and non-responders was very similar between the two protocols. And it was strength training. So they analyzed also the differences in strength gaining between the two protocols, and they were basically the same. So because the hip exercise protocol would kind of include a few quadriceps muscle group exercises as well. So they ended up having similar types of strength gain, at least. So I would say that the two protocols had similar results in the end. And for the only difference between the two protocols was the time that they actually got better, where the hip and core protocol, they got better faster than the knee protocol.
So I've got a question from Kevin Bold here, who's online. And his question is, how accurate is commercially available wearable technology compared to the method that you use for determining hip acceleration?
Good question. So the question was, how comparable is the accuracy of an accelerometer that is commercially available to the actual calculation of the pelvic acceleration? Well, I won't go into accuracy, but there are differences between the two signals. So first off, when we talk about the pelvic acceleration, the accelerometer, the axis of the accelerometer moves around with the person, whereas in the kinematics, that doesn't happen. Now, I did try to correct that by rotating the coordinate system to a local coordinate system to try to account for that. But even when we do that, there are still differences in the signal. And which one is more accurate? I couldn't say. We'd have to compare that probably with some other methods, such as differentiation, integration from the force plate, or even calculating the whole, the center mass from the whole body kinematics. There have been some studies that have done that, but mostly for vertical oscillation and not the acceleration itself. And these segmental analysis seem to overestimate the measures of vertical oscillation. But for acceleration, I don't think there's much work done on that field.
Thanks, Ricky. You mentioned a few times that the model selected certain variables for to separate the two groups. Can you explain how that worked, and probably especially for the support vector machine, like how do you know which variables were contributing to that difference?
Yeah, so we used a feed-forward selection protocol, which we basically added one feature at a time, and then the model would choose the feature that had the highest classification accuracy. Would keep that one and add another one and add all of them. So it basically did a combination of all of the features and extracted which combination would have the greatest accuracy in the classification. Does that respond?
And then you chose the model that had the highest
accuracy, yes, in classification.
So, Ricky, good talk. The reason for the doing the double differentiation for the acceleration, is it to determine feasibility of like a MEM sensor to do this type of classification? Is that like the main goal, is to see how, is it feasible to use the accelerations?
Yes, exactly.
Yeah, and so I wonder, like when you did that, there you had a pretty clean acceleration signal. I'm wondering, did you ever try and play with adding some like noise to that acceleration signal, something that you would see in a MEMS sensor, to see if you can still classify with some noise in there that would be present in one of those sensors?
So the question is, the signal from an accelerometer would be noisier than a cleaner signal from a calculation done from kinematics for the pelvic acceleration. And would there be a difference because of that noise? I haven't done anything to try to add noise, but I am currently working on a study now to try to look into how similar the data is between these two types of accelerations. And using a classification paradigm, it seems that for the pelvic accelerations, they do similar jobs. So I just lost my train of thought here. Sorry. Yeah, so when we compare this using this classification paradigm, it seems that all the information is contained equally in both signals. They're just maybe rotated differently, and there might be some signal noise there. But at least for a random classification, it seems that we can pick out using either one, but that will obviously depend on what is the problem that we're analyzing. So it depends on which are the features that are important to separate two groups.
Yeah, so I think it'd be neat if you, or more powerful for that article, if like you have like clean data right now, and if a company is able to say, this is our error model, or this is the noise that's present in our sensors, and then you could check for them with that, adding that noise to the data and see if it's feasible or not. I think it would probably be pretty powerful to have that.
Yeah, I think that's a good idea. However, the only thing that I see as a problem is that we don't know exactly which are the features, especially when we're looking at principal components. Kind of hard to really interpret them. So we don't know how much that noise influences or not in those features. So I think it would be even easier if we just collected people using the wearables and try to either develop another model or use the same model with this type of data.
Colleagues, Brent.
So when you're adding in that pelvic acceleration, I guess the intent of that was to try and do something more clinically relevant, right? Which is accelerometers in the future. Did you also, when you were doing that, did you still have it combined with the kinematic data as well when you were doing the classification, or did you ever look at it purely based on, like, a classification purely based on just the pelvic acceleration?
For the second model?
Yeah.
So the question was whether I combined joint angles and pelvic accelerations in the second model. No, I only used the pelvic accelerations because the idea was to just use that type of signal.
So patellofemoral pain, it's a joint kind of injury. And so I would have thought that the lower extremity joint kinematics would have, especially the knee, would have led to a better prediction. So I'm always troubled when that happens with prediction models, when I think what should happen doesn't.
Mm-hmm.
So what do you think, what is it about the center of mass excursions that leads to a better prediction accuracy over the joint kinematic?
So the question was, because patellofemoral pain is a knee joint problem, we would expect that kinematics from the lower extremity joints would do a better job in classifying these responders and non-responders, rather than using pelvic accelerations. So there are a couple of things that I could think about. One is the type of model that we use. We use a support vector machine for the second one instead of linear discriminant analysis. Now the support vector machine will only take those subjects that are in the border of that division line between responders and non-responders, and doesn't consider the whole distribution, while as the linear discriminant analysis does. So maybe that gave it a better performance for the classifier. But another mechanical reason that I could think of is that joint kinematics would be the end output of our motor control system. While the center of mass or pelvic acceleration, I would think that it would have a bit more correspondence, a bit more of a stronger relationship with our control system of how we're accelerating and decelerating our body. So maybe that's where it comes from, but that's just a possibility.
What if you were to look at, very quickly, what if you were to look at the joint angular acceleration, a joint moment or something?
So the question was if we could look at joint angular acceleration or joint moments. Yes, that could be a possibility, but I think we started to step away from that just because we would get more and more into complicated methods, and this would drive away from a clinical setting. So it's just easier if we try to make it accessible for clinicians. But yes, that would be an interesting idea to look into, especially if we want to really know what are the mechanical differences between these two groups.
In your cross-validation, did you repeat the PCA every time, or you made the cross-validation after the PCA?
For the cross-validation, I only did it the first time before, the PCA before the cross-validation.
So in fact, the subjects that you left out contributed to the PCA and therefore was still factually in your data.
Yes,
So
that's correct.
Cross-validation.
Yes, that's correct.
Is that the reason why you want to further work on the generalization?
Yes, because well, even if I did a cross-validation using the PCA, this would be an assumption that it would work on the real world, but we don't really have a test set that wasn't involved in that. And typically in machine learning algorithms, it's better if we have a test set that has nothing to do with the development of the algorithm, because sometimes that could have an imbalance between what was the cross-validated measure and what's actually the measure in the test set. So in the end, we only know if it's really working in the real world if we use the test set anyways.
I would agree with that, and I would say that's very likely in our hands most of the time when we use the cross-validation only. We see that the generalization fails.
Yeah, so that's why I was a little bit careful to say there are potentials here. I wouldn't take this model and just implement it. We still have to test how well it would work on the real world.
You have chosen the lower limb joint angles and the hip acceleration. Can you tell me what your thinking was before you started the study? Why these are the variables that you should choose and use in your project?
Okay.
Functionally.
So the question was why I chose lower limb joint angles and why I used pelvic accelerations. The lower limb angles I use because there is a lot of work, not a lot, but there's a bit of work done that looks into, tries to define that there are kinematic subgroups within the patellofemoral pain population. And looking at that, we were thinking maybe these differences in subgroups are related to actually related to not only the mechanics of how they develop or they respond to the pain, but to how they respond to exercise treatment, for example. So that's where we wanted to use the joint angles as a possible input feature. And we also had the example from Dylan's work where he did the same thing using the joint angles from knee osteoarthritic patients. So we had like a former example to say that this type of model could work using this model, especially if we're talking about gait kinematics. For the pelvic acceleration, one, we wanted to make it a little bit more accessible. So,
functionally.
Oh, functionally, yeah. Well, we thought first about the vertical oscillation, because the vertical oscillation, there's been one study that actually looked into vertical oscillation and injured runners and non-injured runners, and they found a difference in vertical oscillation. Apparently, the injured ones have lower vertical oscillation. So I actually started out with that hypothesis, but when I did run this type of classification using vertical oscillation, but it didn't work out. The classification accuracy was awful. After that, we thought about the acceleration because of what I just talked to Brent about, because the accelerations might have a bit more of a relationship with the control of the locomotor system. So that's where we went. But there isn't like a direct connection between that and patellofemoral pain, no.
And this is the one that had the better result.
Yes.
So what do you do with that result?
What do you mean exactly?
Yeah, I mean, you have something that you don't really understand exactly what it does, and that gives you the good result. So.
Oh, okay. So interpreting pelvic accelerations can be a little bit weird and complicated, and we have to make a lot of assumptions to actually go into like what it's happening mechanically when these people are running when we analyze these. But we can tease out a few differences. So these differences in peak magnitude here the scale is like from 0 to 30. So this is actually quite a big difference in meters per second of acceleration. Sorry?
These are two different.
These are between responders as a whole and non-responders. So this is just the average waveform from those two subgroups.
For the principal component 2 and 16.
These are the raw ones. And then the principal components had greater loadings on the around this area that represented a magnitude difference for these peaks, and a few phase shift differences for these medial lateral peaks. So what I was able to try to interpret out of this was this peak acceleration could have some relationship to the stiffness of the limb when it's landing, and that would have everything to do with impact absorption in the knee.
But that's probably not significant.
If we look only at the peak magnitude, probably not. I think I have that data, but I'm not sure if it was significantly different or not. It might have been actually, but I'm not sure. But still, we're talking about principal components and not the magnitude itself. And this is one of the components that is represented by this PC. And it would be actually a combination between these. And when we look at the scores from the PCs, they are statistically different between the groups.
Yeah, but you always move sideways. You know, you always say the groups were different. What I am interested in is to understand functionally what was the difference and how can we use that, because I think that may help you in treatment modalities, if you understand that.
Yes, I agree. But for that purpose, that wasn't the main purpose for this second study. But for that purpose, I think I would use other types of variables to try to tease out what are the mechanical differences between responders and non-responders.
So are you saying you choose those variables only for grouping, or primarily for grouping, that you can distinguish between groups?
Well, yes, exactly.
Michael, Lars, Scott,
So, nice talk, Ricky. To follow up, I guess, on kind of Benno and French's point, like when I take together your two studies, the first one shows that, like, you know, hip flexion at initial contact seem to differentiate the two groups. And it was also ankle dorsiflexion at initial contact. And then if you take these results here, you have this clear difference between anterior posterior acceleration, right? So it seems that, I mean, the first set shows that maybe they're striding out longer, right? They have this overextended knee posture, which may be related to like a lower step rate. And then this also shows that this could be related to, you know, a greater deceleration or something, which all to me seems to point to maybe some kind of like increased negative work of the knee, or if you wanted some kind of like just increased patellofemoral force. So I can maybe make myself believe that the reason maybe some people don't respond is that they have this excessive patellofemoral joint force, and strengthening doesn't do anything to change that, right? Like we know that strengthening doesn't change the way you move. It might help how your tissue tolerates the load, but maybe it might be, you know, the non-responders would respond better to like some kind of gait retraining intervention, and these other people who are in strengthening respond well because, well, they don't really have a very high patellofemoral joint force. They just happen to like maybe do too much, right? That kind of too much too soon idea becomes PRP. So have you thought about it in that way, where you can discriminate people, like moving forward, right? Like the idea is, what can we do with these non-responders? Is it gait retraining? Is it education, telling them what not to do, or is it, you know?
Good question. I like that. So at first, when I started this, I thought I would be able to tease out what are the differences between responders and non-responders. Turns out it was much more complicated than I expected, and I bit off more than I could chew. But so as I said, as one of the limitations for these models, it's kind of difficult to tease out what are these mechanical differences using this type of model. And we don't really know what to do with the responders, because this model is actually talking about who responds specifically to exercise, and not even exercise in general, specifically to a hip and knee strengthening type of protocol. So we know that who is a responder here responds well to this, but there are other types of treatment out there that could be used in patellofemoral pain, and that's what we should try to do with these other non-responders, such as using insoles, which has been shown to also decrease pain in the short-term duration for these patients, or gait retraining. JF Esculier from Vancouver does a lot of work into like changing step rates while you're running to try to look into whether it has an effect on pain or not, and he has had like good results in that. So maybe for the non-responders, these other types of treatments are more adamant. But the thing is, they don't respond to exercise. So why put them through the 6 weeks of treatment and then after the fact say, oh, you're not a good fit for this. So if we know out of the bat, oh, you wouldn't probably be good at doing exercise, then we can try other types of treatment that aren't really what is primarily indicated for these patients.
Yeah, and I guess as a follow-up to that, I you know, like some kind of being able to identify the kinematic or kinetic differences between these groups would be highly useful, right? Like you could do some kind of, I don't know, two-dimensional, or a clinician can view someone running and go, oh, this person, you know, I don't know, runs very heavily, right? And so maybe they might not as well benefit as well from a pure strengthening.
Yeah, I guess I could see, this is a very interesting question that I think it's important to be answered, which I can answer with these studies for sure. And I see that happening in two ways, I guess. One is we could try to develop different methods for different types of interventions, which is something that a lot of people do. Like, I think there are 2 or 3 groups in Australia that work on patellofemoral pain, and they're really interested in insoles, and they're looking into prediction models of who would respond well to insole or not. But there apparently aren't having too good of results trying to tease out what are the prediction models. And maybe it's because they're only using those clinical variables from pain, age, and maybe they should go more into biomechanical variables. And the other way that maybe we could answer that is to dwell into those biomechanical data, such as using the joint angular acceleration or moments such as Brent mentioned, and other types of variables that could give me a better idea of what are the mechanics that are going on.
Lars, there's a colleague behind the pillar who had a question, but he was behind the pillar so he couldn't see, but he had a question, so who?
Well, that might have been me.
Please.
I just a question about the model. I'm just trying to get an understanding about hitting noise and stuff. So if you just randomly reshuffle the labels of like responders and non-responders, and you fit a model to that, how good is the? Can you train up a high accuracy model on such a relabel?
Potentially, yes. But for example, I did try to use other types of variables for these classifications, and they didn't do so well. For example, I used the vertical oscillation data, and I think the accuracy went, I think it was in the low 50%, 55%. If I use only the clinical data, it goes, I think, to low 50s as well, which isn't significant when most people actually are responders to treatment. So, but yes, that's why we need to do this, use a test set of subjects to actually validate them, these models.
I just gave it to you. Oh, so Scott, ours I had this.
So you did better with the pelvic accelerations than you did with
Where is
the
it
joint
coming
angles,
from?
right? I'm here. You did better with the pelvic accelerations than you did with the joint angles.
Yes.
But if I understand what you did, you have less degrees of freedom in the model with the pelvic accelerations, yet you got a better fit, essentially, which to me means that acceleration is a better thing to classify based on, at least from this study. And maybe the relationship to kinetics, possibly, had you multiplied by the runner's mass, you would be sort of close to the force acting on the center of mass. The pelvis is sort of close to it. And so then that leads to the question, do you have ground reaction force for these runners? Were these data collected on a treadmill with a force plate?
I think we do have for some, but not for all of them. So that would be an interesting. I haven't looked into that data. I think our group usually has a bigger interest in the kinematics. So usually the force data, they usually are collected when they are collected here in our lab, but we also in our database we have a lot of patients that were collected outside of here in clinics that have the system.
This was a 5-year randomized control trial, so we have ground reaction force data on the Vertex treadmill for about half of them. About half.
It would be interesting if you just did a simple like inverse dynamics to get joint forces and moments. And rather than classify based on the joint kinematics, the joint kinetics, if you do better. Because to me, accelerating things is how things become damaged.
Yeah, so, sorry, yeah. Finish.
So that's would be related to stress.
Yeah, that's, I think, in line with what Brent was asking, why would the pelvic acceleration do better? I think it's because exactly the accelerations would have a better relationship with what our control system is doing. And it would be definitely interesting to try to do that. But again, one of the reasons that we went into this direction is because of accessibility.
Yeah,
but if we wanted to go further into what are the mechanical differences, yes, that would definitely be a very good option.
Well, the thing I'd like to see reconciled is if you had more detailed kinetic data, you should do better. You had more degrees of freedom in your kinematic data than you did in your acceleration data. And you did better with the acceleration data.
Yeah,
So-
I completely agree with you. And yes, going from this line of thought, I would think that using force plate data and inverse dynamics data, I would get better results even than just using pelvic accelerations. It's just a question of feasibility in a clinical setting. So if we wanted to ask that question specifically, yes, I think that is the direction that we should be going.
So a comment and a question. So the comment is really simple. It's that I always like to do some simple sanity checks with data. And an example is for your accelerations, you want the vertical acceleration to average out to G, and you want the other accelerations to average out to 0. And I don't think this is going to affect your particular results, but I think it's important for allowing other people to replicate the study. Is that if I look at the medial lateral, I suspect that it looks like the medial lateral is on average more positive than negative. And so that would say that there's probably some issue with the mounting of the accelerometers.
Oh, these are not accelerometers.
Oh, okay. Well, even if it's not accelerometers, I want the average medial lateral acceleration to be 0, and it looks a little bit fishy there.
Yeah, I think one issue is that these are average signals. So these are not like from individuals. So maybe that's where it comes from as well.
Well, it's just that for each individual, it also has to average to 0. So if you add up a bunch of individuals, that still has to average to 0. So that's just a comment. I don't think it actually affects your results here. But my question is, I'm really curious about what people were doing, whether they were running or not, both for the treatment period and for the visual analog scale. And this goes back to a talk I saw a long time ago. It was some sports medicine doc. And he was saying that the #1 most effective therapy for running injuries or sports injuries in general was rest. And he said the issue with serious athletes is that they never want to rest, or even if you could force them to rest, they want to ramp up too quickly. And then he thought the whole issue of the different therapies and treatments you do is whether you can help manage that so you can get them up to where they would like to be sooner, as opposed to, fundamentally affecting whether they get better or not. So then my first question is, it could be that let's just say that that person was correct. Then that means that the #1 factor in whether someone responds is just whether they stop running, or whether whatever they were doing during that time was enough different from what caused the pain in the first place that they could have recovered. And then maybe the therapy helps plus or minus some amount, but really, if they stop running, that might be the most effective thing. And then the other thing is, when you do the visual analog scale, are they running or not? Because one possibility is, okay, they stopped running, the pain went away, but then they started running, ramped up too quickly, and then they're in pain again. And then that could also be independent of the therapy. It was just not enough time or too fast of a ramp up. And then also it could be that they stopped running and they're still not running, in which case I would hope that their pain is low, but it's also possible that, they just have some chronic injury that's never going away. So, there are all these different combinations. So then I'm just very curious whether, were they running or not?
Yeah, so unfortunately, I don't have the specific data to tell which patient was actually continuing their activity or not. But as we said, they were instructed to keep doing their daily activities. Some people probably stopped running, some people didn't, and I think it would be a mixed batch between responders and non-responders. But there are some other clinical trials that control this in a much better way. So Jeff Schoolier's group in Vancouver, for example, he just did a randomized control trial looking into these differences in changing stat frequency or just education or exercise-based therapy. And he controlled this very well, if I'm not mistaken, by telling them, look, if you want to run just run before you start having pain, and don't let it aggravate. And apparently he was able to control these factors, and still for all of the groups he had responders and non-responders. So we still have like this subgrouping independently if people stop running, or independently if people don't stop running, because I think in that study people didn't stop.
And very quickly, we have logbooks on all of this. So for the 199 patients, they kept weekly logbooks. They checked in with an athletic therapist, athletic trainer, once per week. I know we looked at the data, this years ago now, but well over 80% of them continue to run, just reduce their mileage. But we haven't included that in any publications. It just wasn't related to the primary variables of interest. Good point, though.
Last question, Vincent.
What variability do you have with your PC16, and how many points did you use of your graph? 100? You have 100%, so you have 1% intervals?
Yes, so 300 points, 100 for each direction. And it was a low variety. I think I have this data here. Yeah, so overall for these 4 PCs, less than 12% of the variance was explained.
So less than 12%. So you are in fact on the lower edge of your variability.
Yes.
Is that trustworthy?
I'd say there might be some problems. There might be some noise issues that are coming into these PCs, especially PC 58 and 69. But for example, PC.
Most likely less than 1%.
Yeah, exactly. So I don't trust these very much, and they didn't bump up the accuracy that much. When I look into just using PC2 and PC16, these bumped it up, but just a little bit. So these are the two main ones that are driving the model, if I'm not mistaken. But yes, I agree. There could be some problems with the principal component analysis process. But there are a few studies that looked into like including these higher order PCs to do these classifications, and they seem to be more sensitive in the detection of these subtle differences between subgroups. So Ankun Finyomark from our group, he did some work on a lot of work on these classification algorithms, and what he saw that if we don't include these higher order ones, then we just push the accuracy down. So I think we need a test set to understand if this is really noise, or if this is really just subtle changes, subtle differences between these subgroups.
Wonderful. Let's thank Ricky again. We'll come back next Thursday. We will welcome Jacqueline Rios, PhD student of Dr. Walter Herzog, to tell us if exercise and dietary intervention is effective in treating metabolic OA. See you.